Shaden, let's start with you. What does individuality mean in healthcare?
You know, Glenn, it means a lot of things, and it really depends on which perspective you take. There certainly can be from a genetic perspective in response to medication and personalized medicine. Individuality can also relate to our mental state and the circumstances that lead to that. It can relate to your social determinants of health. It can relate to your belief systems. Everything I've mentioned really affects outcomes in healthcare.
Well, Shaden, with this in mind, how do we begin to operationalize inclusion?
When you talk about operationalizing inclusion, it's not enough to just hire and say, all right, we have diversity, we're inclusive. It's much more than that. So the first step is inclusion. The next step is really providing that avenue for voices. And the third and very necessary step is to take action based on these diverse opinions and the inclusion that you're purporting to have. It's really nothing without the action.
You know, it's very interesting because it's the intention. So the intention is there in a lot of places now, right? But then the next step is the hard one. The next step is now you have to listen differently. Now you have to listen to everybody. You need to have the people that are going to be affected by your decisions at that table. So we need to teach them the language and empower them that we really want to hear what they have to say, and then bring them at the table. So it's a little bit of work, but it has happened with patient advocates, for example, so it can happen at any level.
Why do we in healthcare focus so much on diverse representation but not inclusion?
Diverse representation is easier. Finding faces to sit at the table but not doing the work to keep them there is an easy solution. It takes really hard work to make sure that diverse leaders stay. So diversity is easy, and diversity, equity, and inclusion we know has been around since the 60s, and we know that we're still talking about it. So we need to do something different. So that is why we focus there, because it's easy for the eye to see and we're not really making a change.
And DeAnna, I know that social determinants are extraordinarily important for you. I mean, you've often said that we need to change the definition of health.
We do need to change the definition of health to be more inclusive, to include clinical, social, and economic outcomes. But I wanted to go back a little bit to the standards versus the individualized care. Glenn knows, but May 7th, so three days from now, I had a heart attack last year. And I said to my provider, my blood pressure hasn't been normal. My arm is numb. My hand tingles. You're fine. Your blood pressure is perfect. It's 120/70. That's perfect. I said, it's not perfect for me. It's normally 80/60. They do it twice. No, it's perfect. But I knew my basic. So at that point in time, how do you look and you do something different for me? When you looked at my calcium test score and it was a little irregular and you cleared me for a surgery that was three weeks prior to my heart attack, didn't you think something else was up and you maybe could have done something different, as opposed to looking at the standards? So how do we create standards, but then listen to the patient and then allow AI, so if we could take bias out of AI, to then lead us with different algorithms to also help us navigate a really complex system while also listening to the individualized needs of our patients?